Hello, good afternoon, everybody. A warm welcome to all of you to this event, episode 5 of One Among You, which is an initiative by Epistate Health Singapore. It's an absolute pleasure to host today's session, and I'm truly grateful to see all my passionate dental professionals and enthusiasts following and joining us today. Well, to introduce myself, I am Dr. Niharika Jain Gupta, an endodontist from the city of Jabalpur, Madhya Pradesh, India. I'm currently associated as one of the directors in endodontics, global endodontic vertical from Epistate Health Singapore. So, uh, today I welcome all of you and I'm inviting all of you to join us in this program, which is all about celebrating the exceptional talent of our outstanding dentist. People who walk with us, who blend us into the crowd, yet possess extraordinary skills and dedication to their craft. So today, we had the privilege of showcasing their remarkable cases, insights, and expertise, fostering learning and collaboration in our field. And one of the key speakers of today's session is Dr. Shivansh Aggrohiya. Um, well, just to make a very small introduction, Dr. Shivansh recently won third prize in the endodontic case contest that was organized by Epistate Health Singapore. And I welcome you, doctor, to introduce him. Just a minute, please. So, as I mentioned, today's speaker is Dr. Shivansh, and Dr. Shivansh has done a graduation from Maulana Azad Institute of Medical Sciences from New Delhi, and currently a final year postgraduate student in the Department of Conservative Dentistry and Endodontics from SGT University, Gurgaon, Haryana. I welcome you, Dr. Shivansh. The podium is all yours. So, without much ado, let's dive in.
Good
The screen
afternoon.
is all yours, Dr. Shivansh. Yes.
Thank you, ma'am. Good afternoon, ma'am. Good afternoon, everyone. As Dr. Niharika, ma'am, introduced me with kind words, I myself, Dr. Shivansh Aggrohiya, a final year postgraduate from the Department of Conservative Dentistry and Endodontics in SGT University, Gurugram, Haryana. I would like to thank Epistate Health in collaboration with SRM Dental College and ICD 2025 for giving me an
Ma'am.
opportunity to present a webinar among you all.
Yeah.
I would also like to thank entire Epistate Health team, including Dr. Niharika ma'am, for
Sorry, ma'am.
carrying out
Yeah.
this webinar.
Okay, ma'am. Thank you.
Uh, just a minute, please.
Okay.
Sorry. I'm
Sorry, ma'am.
extremely sorry, Dr. Shivansh. I would
Yes, ma'am.
Okay.
It's
request
okay.
all of you to please keep your
Okay.
phones, mics
Yeah,
off.
ma'am. Okay.
Yeah.
Sorry, ma'am. Bye, ma'am.
I request all of you to please keep your microphones off. Also, if you have any doubts during the session, please feel free to type the questions in the chat box, which is there on the right side of the screen, and by the end of the webinar or at the end of the webinar, Dr. Shivansh and I, we both are there to answer your doubts. Also, if you have any doubt after the session, please feel free to email us. Thank you so much. Over to you, Dr. Shivansh.
Thank you, ma'am. I would like to thank complete entire Epistate Health team and Dr. Niharika ma'am for carrying out this webinar. Now I would like to begin my presentation. Ma'am, is my PPT visible?
Yes, Shivansh, it's visible.
Okay, let's start. So, before I begin my webinar, there's a beautiful quote. Opportunity tends to reveal itself to those who are actively seeking it. And for me, Epistate Health Singapore was the one. Starting my webinar, not your average premolars, a tale of hidden complexities. beginning with its contents, introduction, case presentation, discussion, and conclusion. Jumping to why premolars are called as an endodontic enigma. Because they present unique challenges in root canal treatment due to their complex anatomy and variability. First, for root and canal variability, this is very unpredictable and it makes cleaning and shaping and obturation very difficult. For maxillary premolars, according to Kahn's EJ et al., the incidence of one root varies from 22% to 49.9%, two roots with 50.6% to 72%, and three rooted premolars are from 0 to 6%, as in my case. According to Vertusi, the incidence of three canals in maxillary premolars is 5 to 6%, as in my case. For my second case, for mandibular premolars, according to Sultan M. Al-Samartri et al., the incidence of one root with single canal varies from 89 to 93%. Two rooted premolars show variation with two canals from 7 to 11%. According to Zilich et al., the incidence of two roots with three canals were very rare and 0.4%, as in my case. Premolars have very thin and curved roots. The roots of the are so thin and the curves are so wide and the tooth are dilacerated, increasing the risk of perforation or instrument separation during the treatment. They have a lot of accessory canals and isthmuses where they have intricate canal networks, including isthmuses and accessory canals that can harbor bacteria if not properly cleaned and shaped. Jumping to my first case, maxillary first premolar. A 28 years old male patient reported to the Department of Conservative Dentistry and Endodontics with a chief complaint of sharp shooting pain in upper right back tooth region for 2 days. He had no significant past medical history, but on revealing the dental history from the patient underwent treatment of upper right tooth 5 days back after chronic pain since 4 months from a nearby dentist. On clinical examination, it was found that the tooth 1-4, that's the maxillary first left premolar, the tooth was tender, first premolar, the tooth was tender on percussion. There were no signs of swelling, pus discharge, or a sinus tract, and no other tooth being symptomatic. The vitality testing was done with cold test and electric pulp test. The tooth 1-4 gave early response, indicating a diseased state of pulp, and the tooth 1-3 gave normal response, indicating a healthy pulp. A radiographic examination was done and RVG was taken, which revealed root canal, initiated tooth, and a periapical lesion with respect to 1-4. As you can see in this radiograph, we are able to distinguish three different root canals as well as three different roots for the first premolar. That is very rare. The provisional diagnosis was made of symptomatic irreversible pulpitis with apical periodontitis, the patient for which was advised to undergo root canal treatment. The root canal treatment procedure was initiated after obtaining an informed consent from the patient. For local anesthesia, a middle superior alveolar nerve block was administered, and rubber dam isolation was done. The treatment was carried out under the magnification using Labomod Prima DNT microscope, which is in my hospital, and with engine driven Epident V plus ultra flexibility night eye rotary file that were given to me from Epistate Health team. This is a picture of me working for my daily cases. And here you can see precision begins with vision, and microscopes make the invisible visible. The advent of magnification aids has greatly revolutionized dentistry, and especially in the field of endodontics, where we work with minute canals and minute inter tooth. Coming to next slide, access opening, refinement, and orifice shaping.
Doctor,
Localized.
Dr.
Yes,
Shivansh, your screen is not, yeah, now it's visible. Yeah, please, sir. Sorry, go ahead.
Okay. Okay. Coming to the treatment, the access opening refinement was done. The caries was excavated. We're using sterile high-speed diamond round burr, endo access burr, endo Z burr, and StarTex tips. These tips are basically ultrasonic tips that prevent overcutting, and they are very good in refining the excess cavity and the canal orifices and the pulp chamber. The canal orifices were located with the help of Hufredi DG16 Endodontic Explorer that is very fine, and it helped me to identify three different orifices that were buccally present, two mesiobuccal and distobuccal, and one palatally present. The orifice enlargement was done first using Epident 1904% orifice shaper. Next, working length determination was done with the help of 15K file using an electronic apex locator, Root ZX Mini, and it was verified by periapical radiograph. As you can see, the rubber dam is placed, no margins are leaky. It was made sure to use liquid dam to prevent any saliva contamination. 15 number hand files were used, and in the radiograph, it's visible that two are buccally present and one is palatally present. So why an apex locator? Unlike traditional radiographs, which can be influenced by angulation and anatomical variations, apex locators offer real-time, objective, and highly accurate measurements based on their electrical resistance between the periodontal ligament and the oral mucosa. The working length is the distance from coronal reference point to the apical constriction, where cleaning, shaping, and obturation should end. The benefits of using an apex locator are it prevents over instrumentation. So it will prevent any extrusion of irrigant or niti file or hand file that may harm the periapical tissue. And yes, it prevents under instrumentation as well, so that complete debridement of the pulp takes place and no pulp or bacteria are left behind. The cases with anatomical complexities and varied canal, it helps give us a complete and accurate working length. It improves our treatment success. So next step was to achieve a glide path. A glide path is basically a smooth, reproducible tunnel from the canal orifice to the physiological terminus, allowing safe mechanical preparation. Its importance is to reduce the risk of canal transportation or file separation, and to enhance the irrigation and effectiveness and prevent formation of ledges. It promotes accurate working length determination so that the files that we use sequentially reaches till the working length and it debrides the complete pulpal tissue. The glide path file used was 1802% after the use of 1904 orifice opener. As you can see in this picture, the glide path file was made sure to go to the working length in an in-out motion. Next, the chemomechanical preparation starts, wherein during instrumentation, a small volume of 2 ml of sodium hypochlorite solution in each canal between each file change was done, followed by saline irrigation thoroughly, and the recapitulation was done with 10K file till the last rotary file, followed by a final irrigation protocol. In Epident rotary file system, it comprises of first an orifice opener, then it comprises of two glide path files, and then it comprises of different tapered NITA instruments such as 2004%, 2007%, and in my case, I used my last file 2508% to debride the necrotic pulp tissue. These were my steps followed. As you can see, in each cases, the canals are wet. That prevents binding of the file in the dentinal tubules and prevents breakage or formation of a ledge. The canals were wet with the help of sodium hypochlorite and during the entire procedure. And by after completing the last rotary file, 2508% Epident V plus, endosonic activation of sodium hypochlorite was used. Now, studies and literature have shown by activating sodium hypochlorite with the help of an endoactivator, it increases the power and efficiency of sodium hypochlorite to go in the dentinal tubules and flush out the debris and the bacteria hiding in it. Coming to my irrigation protocol that I followed was after final cleaning and shaping. First, 5.25% concentrate heated sodium hypochlorite 5 ml per canal was used to flush out the debris, bacteria, and second, it was later endosonically activated. Now, for enhancing the property of sodium hypochlorite, I here used two things. First, that solution was heated with the help of intracanal heating tip to a temperature of 150 degrees Celsius, and then later activating the solution, agitating it with the help of endoactivator for 60 seconds per canal. The canals were then flushed with saline, and then EDT 17% solution for 60 seconds was sonically activated in each canal. The reason why I use EDTA in all my canals is with the help of sodium hypochlorite, we can easily remove the organic part of the tissue, organic part of the debris. But for removing the inorganic part, EDTA works well. It dissolves all the smear layer produced and leaving the canal clean. And further, last once again, same procedure for hypochlorite was used to disinfect the dentinal tubules that were now open with the help of EDTA earlier. Final flush of a saline was used in each canal, and then the canals were dry and obturated. Coming to the pictures, first the dried canals were seen after chemomechanical preparation. As you can see, the canals are cleaned, and we can easily appreciate the two canal orifices in the buccal and one canal orifice in the palatal. The procedure was forwarded with the help of bioceramic sealer, or we can say calcium based silicate based obturating material. They are very good in their flowability and antimicrobial property, and to create a tight seal between the gutta and the dentinal tubules. Now later, the gutta were taken and the tooth was obturated with the help of obturation pen by a technique which is known as cold compaction, single cold technique. The master cone was taken by verified by intraoral radiograph. After then, the further obturation was completed. As you can see in the first radiograph, we can appreciate the outlines of the three different roots of the first premolar. And then this, in the second part, the obturation pen helped me to seal the canals, obturate the GPV to the orifices of their split. Next, restorative part begins. Saddle matrix was placed, wedges were placed, and selective edge technique was used, and the fifth generation bonding agent was used to completely clean and seal the dentinal tubules and increase the bonding efficiency for the next composite placement. First, the orifices were sealed with the help of flowable composite, and then later on, the bulk fill composite was used to final and complete the post-op restoration. This is a clinical picture after final restoration, and the patient was referred in the department of prosto for its prosthesis. Now in the last final picture, you can clearly see the obturation was done till the working length, and it was made sure the canals were sufficiently irrigated and cleaned to prevent any further contamination. And in coronary part, the restoration margins were tight, leaving no gap for the entry of oral fluids or bacteria. Coming to my second case, it was a mandibular second premolar. A 41 years old male patient was reported to the Department of Conservative Dentistry and Endodontics with a chief complaint of sharp shooting pain and severe sensitivity to hot food in the lower left tooth back region since last 15 days. There was no significant medical history, but yes, patient revealed that he had root canal treatment done in the lower left molar tooth 4 months back from a dentist in a nearby area. On clinical examination, it revealed a deep class 2 caries with respect to third quadrant, second premolar, 3-5, and a dislodged restoration with respect to 3-6, the molar behind it. The tooth 3-5 was tended to percussion with no signs of swelling, post discharge, or a sinus tract. On vitality testing, it gave an early response indicating the disease state of the pulp. A radiograph was taken, an RVG was taken, and as you can see, it reveals a deep class 2 caries lesion with respect to the second premolar, and an RCT treated tooth on the first molar with a dislodged restoration. In this radiograph, we can clearly appreciate the split is very deep and almost in the mid of the tooth, and splitting into two different and three different canals with a periapical lesion, and thereby the patient symptoms was tender on percussion. So a provisional diagnosis was made of a symptomatic irreversible pulpitis with apical periodontitis with respect to 3-5, and that for him, patient was advised to go for a root canal treatment. After localized oral prophylaxis, rubber dam was placed and it was made sure there was no leaky margins with the help of liquidam and Teflon, and the working length was taken similarly as my first case with two hand files 10 number K file on the buccal side, mesobuccal and distobuccal, and one in the lingual side with a 15K file. The chemomechanical preparation was similarly done in this case. First, the orifice opener was used 1904%, and then later on, the glide path files were used to reach till the working length and to prepare a reproducible canal and path to further uh, allow the other files, consequently next sequential files, to reach till the working length and to prevent any transportation or formation of ledges and to go beyond the curvatures. And the next first file 2004% was used, and then the canals were again endosonically activated with sodium hypochlorite, and then the further canals were prepared till 2508%. In these steps, all these steps, one thing is very important, that is to recapitulate in between every sequential increasing file number. That is done with the help of a 10 number hand file and a lot of saline flush. Coming to next steps, the master cone was taken, and finally an obturation was done with the help of same bioceramic sealer, and the post-op restoration was completed, and the patient was referred for prosthesis with respect to this tooth, and the post-op restoration adjacent to the tooth, that is of first mandibular molar, was done, and the patient was advised for a only crown preparation. In conclusion, managing root canal treatment in the first maxillary and second mandibular premolars, it demands a lot of understanding of their complex and variable anatomy. So before beginning any case, first we have to win the case in our mind to tackle will be able to tackle this situation, tackle the tooth. So we need proper thorough knowledge of it and proper steps and a guide to guide us to the different paths and plans during the endo treatment. These teeth often present with unexpected root canal configurations. You never know what your tooth may reveal when you look into a microscope. These teeth often present with unexpected root canal configurations, making careful radiographic interpretation, magnification, and tactile exploration is very essential. By staying vigilant, embracing advanced diagnostic tools, and adapting our techniques case by case, we are able to challenge these cases with ourselves and to finally achieve the success. I would like to acknowledge my head of the department, Dr. Sumit Sharma sir, and my professor ma'am, Dr. Astha Arya, as well as my reader sir, Dr. Gaurav Thapak from the SGT Dental Hospital and Research Institute, Gurugram, Haryana, as well as complete Epistate Health team, Singapore, SRM Dental College, and International College of Dentistry as well. Thank you. For any queries, please feel free to reach out to me, Dr. Shivansh Aggrohiya, my WhatsApp number and my email ID and Instagram ID. Thank you.
Thank you. Thank you so much, Dr. Shivansh. It was a very nice case series of cases meticulously done by using advanced endodontic gadgets. And so the basic idea of this entire program is not just to show complex canal anatomies, but to show simple cases which are done meticulously by the passionate dentist. So thank you
Thank you,
so
ma'am.
much. And maybe you can go ahead with publication of, combine, you can club all these cases. If you have some other cases, you can club them together and publish a nice case series. We will be
We'll
there
definitely
eager
look into it,
to
ma'am.
support you.
Thank you, ma'am.
Yeah. Thank you so much. Thank you for joining.
Thank you,
And
ma'am.
yes, the recording of this session will be available on our YouTube channel. Besides, if anybody has any doubt, please feel free to contact us. It was so kind of Dr. Shivansh for sharing his email ID and his number. So if you have any doubts regarding premolars, the enigma of endodontist, so please feel free to contact us. Thank you so much. And stay tuned. We will share the details of One Among You, episode 6 of our series, and we will release the information soon. Please feel free to follow us on our Instagram account and Facebook accounts. We are coming up with some more exciting works for all of you in the form of contest or presentations. So happy Sunday. Thank you so much once again, Dr.
Thank you,
Shivash,
ma'am.
for the
Thank
wonderful
you,
presentation.
everyone.
Thank
Thank you,
you.
ma'am.
Thank you so much.
Have a good day, all.